It's 3 p.m. Can start now, Doctor?
Okay.
Priscilla.
Good everyone. Welcome to the webinar organized by College of Physicians Malaysia. We are now in Geriatric month, and the topic for today is confused patient navigating hospital. We are very delightful to welcome our person, Dr. Saidu, who is a consultant geriatric UMM with special interest in falls, and also our speaker for today is Dr. Muhammad Ali. Without further ado, let's welcome Dr. Nur.
Hello, welcome everybody. So this webinar was done every Thursday, organized by Medical Hospital Taiping, is it? On behalf of College of Physicians, and I would like to welcome Dr. Rosmahani, who is currently working as a geriatrician and internal medicine physician at Hospital Kuala Lumpur. She's completed her Bachelor of Medicine and Surgery from University of Auckland, New Zealand, and she did her master at University of Malaya in 2015, where both of us have been working together closely. So she's a very close friend of mine. In the between, she has been working in many central hospitals and has been dealing with delirium patients very frequently. And it will be an interesting talk from our experienced geriatrician. Without further ado, I would like to welcome Dr. Rosmahani.
Thank you, Prof. Izzati, for the kind introduction. I will share my slides now. Okay, so is the slides on screen?
Yes, Doctor. Can see.
Okay. A very good afternoon to everyone. My name is Rosmahani. I'm currently stationed in Hospital Kuala Lumpur. Today, for this afternoon, I'll be talking about navigating delirium in the hospital. So delirium has been around for a very long time. Actually, delirium actually derives from a Latin word that actually means delirare. It actually literally means to deviate from track, or in the British slang, it means out of the furrow. So back in the 1st century, Celsus actually first used the term delirium. He actually described it as sick people, sometimes in a febrile paroxysm. They will lose their judgment and talk incoherently. And when the violence of the peak is abated, the judgment will return presently. This described delirium being very acute and fluctuating, and resolution of symptoms. Now this is Hippocrates. He described the forms, some of the symptoms that he observed in delirium, especially what he observed during an episode of rhinitis, or basically inflammation of the brain. He described them as moving before the face, hunch in the empty air, pluck mat from the bedcloth, pick up bits, and snatch chaff from the walls. And he actually recognized, for those who actually have these symptoms, it actually carries a poor prognosis, and actually he noticed that these patients tend to die. So if you look at it, centuries later, there are many words that we use or subconsciously use to actually describe some features of delirium. And when I was a houseman back in HKL, my consultant surgeon would use the term ICU psychosis for patients coming out from ICU and behaving abnormally. Other terms that's commonly used are acute confusional state, acute brain failure, having encephalopathy, altered mental status, and for some people we use subacute befuddlement, organic brain syndrome, reversible dementia, and acute reversible psychosis. Now, this today is actually a very, very big topic and a very big magnitude to talk about. But for the purpose of the next half hour and so, I will actually be focusing on the prevalence and significance, predicting it, how do you assess it, and just touch briefly on management. Now, let me start off by saying that delirium is extremely common. It's extremely common in hospitalized patients. Upon admission, about 9 to 25% will actually have some symptoms of, or actually presented with some form of delirium. And the longer they stay in the hospital, up to 30% of them will eventually develop delirium during the hospitalization. Now, this is actually true because this is your typical patient who comes to the hospital. This is probably dispatchee with maybe 60, 70 years old. He has an acute illness, or he might be feeling a bit poorly, maybe had a fall. He will be presenting to the hospital and goes through emergency department. And from the emergency department, depending on how sick he is and how crowded the emergency department is, he may even be discharged well, or he may need to be admitted. And the decision to be admitted as an inpatient will also depend on whether they'll be admitted to the medical ward or surgical ward or any other wards, or whether they are extremely sick and need to be admitted straight to ICU or high dependency setting, or they actually have an acute illness, surgical illness that require operation. And subsequently from this, they might actually end up back to ICU HDU setting or even back to the medical surgical ward, and eventually they will all be discharged, hopefully. All right, so they're all not very straightforward. At any time of this pit stop, they can actually eventually develop delirium in any of the pit stops here. Now, I'm just showing you a bit of a study. This is actually a study by Coach. It actually shows looking at 1 year prevalence of delirium and the impact of hospitalization across 34 services. It's a prospective cohort study. They were using the delirium observation screening scale and the intensive care delirium screening checklist. So over that 1 year, across 34 surveys, they found that the prevalence of delirium was around 32%. And the odds to develop delirium was highest for intensive care unit and actually lowest for surgical unit. And what they found was that in patients with delirium, they tend to be older, they tend to be hospitalized twice as long, they're more commonly to have pre-existing cognitive impairment or dementia, they're more likely to die in the inpatient, they are more likely to be admitted and or discharged to an institution. So now it comes back to the question, why is delirium is important, and why is delirium in our hospitalized patients are important, right? So as I've actually explained to that just now, so delirium is actually a very significant predictor of mortality. So if you presented to emergency department with delirium, it has been shown that your 6-month mortality is actually higher for up to around 70%. So if you come with delirium, your chance of dying is actually much increased after 6 months. And this is also true if you actually develop delirium inpatient. In a prospective study that was actually done, it actually showed that if you develop delirium as inpatient, your hazard ratio was actually increased to twice, 2.11, to develop mortality within 6 months to a year. And of course, patients who have delirium as inpatient, they have increased length of stay. They tend to have functional decline upon discharge and upon follow-up. There's a risk for them to be institutionalized, and they have been shown to have evidence, a strong association between delirium in the hospital and long-term cognitive impairment as well. Now, this is actually a study. If you do a literature search on hospital delirium, you'll notice that most of it is actually looking at, sorry, I'll just go back here. We'll be looking at ICU settings, because this is where most of the research are looking and where the delirium is actually very prominent. So this is actually a systemic review and meta-analysis by Jorge. It looks at the relationship between delirium in critically ill patients and their outcome, their short-term outcome, and upon discharge from the hospital. So the endpoints they were looking for are death during the admission, the length of stay, the duration of mechanical ventilation, and any outcome after hospital discharge. So they actually managed to collect around, pool around 16,000 samples. So they identified delirium in around 31%. And then this is actually the pool data that actually discuss about mortality. So it shows that they also have significantly higher mortality if they are actually are admitted with delirium. And the length of stay in intensive care is also prolonged if you look here. Okay. Not only that their risk of death as inpatient is higher, they do require longer stay in intensive care. And of course, they do actually stay longer for the duration in a hospital. They also find that they are more likely to have longer need of mechanical ventilation. And there were several papers that look at outcome before after that shows increased mortality in 6 months, as I actually explained. After they were discharged from ICU, they actually have higher mortality. It stays around 41% versus 15%. which is a significant number. And there's two papers that actually look at cognitive function after they are discharged, that show that they have worse scores on neuropsychological testing upon follow-up at 3 months and at 12 months. And another paper actually found that the longer duration of delirium is actually associated with worse global cognition at 3 months and 12 months. One paper in particularly actually reported that those who actually survived mechanical ventilation after 12 months evaluation was associated with worse scores in activities of daily living. So just a bit about post-operative delirium in the elderly. So actually it's not really elderly. This is a paper by Robinson. The cohort is actually 50 years and above. So there is a prospective study. They look at patients who are actually admitted for operation. So these are actually electively planned admission. These are actually patients going for major abdominal, thoracic, and vascular surgery. And these patients all goes to ICU. So they want to see about delirium happening after operation, and patient actually went to ICU. But if you look here, we can see, as we can predict, the incidence of post-operative delirium by age actually goes higher as you grow older, which is what you expect. But look at the outcomes of, after the development of post-op delirium. They tend to actually have longer length of stay in ICU. They tend to have longer overall hospital stay, and of course it will cost longer. And post-discharge institutionalization. About mortality, they are at risk of dying more at 30 days and also at 6 months. So they found when they pooled the data, delirium actually occurred in 44% of the older patients after a major operation. And they actually did a calculation and look at that. Pre-existing cognitive dysfunction is a strong predictor to develop post-op delirium. And there's also an increased rate of 6 months mortality. And these are the risk factors that they look for post-op delirium in the ICU. Now, as I mentioned before, delirium is actually very costly, and ICU length of stay in particular, with or without delirium, is very significant. The longer you stay in the ICU, the longer the stay in the hospital, the more it will cost. All right, so this is actually logic. So having said that, can we actually predict who will actually develop delirium? If you can predict who will actually develop delirium, so technically you can intervene this patient who you predict will develop delirium and actually make some intervention or pharmacological or non-pharmacological management so that they won't develop delirium and have all this very poor outcome and actually longer length of stay. So the problem is that you can actually develop delirium at any point. You can develop delirium in ED, during the hospital admission itself, in ICU, during the operation, post-operation, pre-operation. So it's actually not so straightforward. There is actually ongoing development of delirium prediction model. And these models are prediction used by clinicians as a decision support tool to identify and to prevent or treat delirium. But however, the clinical adoption of delirium prediction model has been limited so far, perhaps because the model is actually not so easily integrated into our physician workflow, and it's actually not a blanket rule or actually can be used for all. Okay, I'll just describe it a bit later. So if you do a literature search, you will find that most of the prediction model will be actually looking at ICU setting. So the two common prediction model that you'll come across is actually the pre-deliric model, which is actually prediction model for delirium. And then they actually created something a bit more earlier, which is the early prediction model for delirium, which is pre-deliric. So the deliric prediction tool actually looks at 9 risk factors, which is age. They look at your Apache 2 score, if the patient's in a coma, sedative use, morphine use, urea, evidence of metabolic acidosis, whether it's an urgent admission, and what was the admission category. So these are the 9 risk factors they look for, and then they will aim intervention at. So the pre-deliric model actually included this included some of the pre-deliric risk factor as well. Okay, so what they look for are actually age, history of cognitive impairment, drinking of alcohol, admission category, urgent admission. They also add on mean arterial pressure at the time of ICU admission, the use of steroids, and as well as urea. So the the three predictors in common that they use are actually age, admission category, and whether it's an urgent admission or not. And the markers they use are actually markers of kidney function, which is your blood urea and creatinine. So the next model that you might come across is the Mayo Delirium Prediction Tool, or MDPT. So this actually predictive tool was actually developed from a very large heterogeneous group of patients. So they actually created this to develop a tool that can be applicable towards different clinical patient population to predict those who are at risk for delirium during admission in a hospital. So these are the risk factors they actually identify. But if you look at this, they added some more. So actually it also includes whether you have COPD, whether you have heart failure, whether you have psychiatric illness, or whether you have existing pressure ulcer, or whether you require ICU. And they actually add on some more blood parameters such as hemoglobin, sodium, and medication as well, such as use of narcotic analgesia. So they stratify the patients into low risk, moderate risk, and high risk group, which is more than 30%. And now for post-operative prediction score, I Googled it up. So actually I came up with this is the more common tool, which is actually the Delphi score, that stands for Delirium Prediction Based on Hospital Information. So it looks at 9 predictors, and they look at age, hearing impairment. So they add a bit more about sensory here, a history of prior delirium, which is new, emergency surgery or open surgery, whether there's an increased CRP, low physical activity, history of alcoholism, or the patient needed ICU, will be needing ICU admission. So if the patient has a Delphi score of 7 or more, the probability of delirium development will be high at around 80%. Okay. So the limitations of the prediction score, if you notice what I just showed, the prediction score is actually not the same. Just remember that most risk scores are validated using either medical patients or in one specific surgery type, or actually base, which actually will weaken your translatability towards across general surgical population or general medical population. And again, remember, and how you want to apply it to clinical practice, and will depends on the population and types of patients you are managing. So the scores are actually static. But remember, the journey of a patient is actually very fluid. Patients' admissions are fluid, it's fluctuation. Patient can go in any way. They're not just static at one point. Okay, so back now to our basis of delirium, Okay, so this is actually a picture from a geriatric textbooks by Hazards. It looks at patients about the development of delirium. So when we actually talk about delirium, we always explain to our doctors that not everyone will actually eventually develop delirium. There is such a thing called vulnerability factor, or predisposing factors, and precipitating factors. So if you are actually someone who's vulnerable, for example, you are an older person, or you have actually chronic illnesses, or you have depressions and so forth, and then you actually are faced with an insult or precipitating factors. It could be an acute illnesses, it could be actually multiple medications and stuff. So these actually makes you and tip you towards developing delirium. So it's actually a balance between your predisposing factors or vulnerability and your ability to actually face this insult. So then you will develop delirium. So imagine this is in normal circumstances, and imagine if you're an older person being admitted to the hospital. So in hospital, there's much more precipitating factors here. We have our sensory issues. There are lack of daylight. There can also be lots of noise if you're in a high dependency setting. Being in a mechanical ventilation, being on a BiPAP, on a non-invasive ventilation, medications that's being given, such as opioids or sedatives. If you are actually having poor comatose state, ataupun confusional state as well, or depending on what illness that you're having, and also based on your illness as well. If you come in with severe illnesses, you probably will. These are actually very noxious insult to actually tip you towards delirium. So in hospital, your risk to develop delirium, especially in the older person, will be much higher. So roughly speaking, we can classify in the hospital, your factors to develop delirium into acute illness-related factor, medication-related factors, and environmental factors. acute illness related factors will be having severe illness, or having a trauma, having sepsis, needing ventilatory support, or very severe hypoperfusion with metabolic acidosis. Medication-related factors can be being given benzos, anticholinergics, opioids, and even steroids has been associated with development of delirium. And of course, we have environmental factors such as the increase of noise, lack of daylight, and admission to the ward without someone familiar to them, language issue. These are all would actually increase the risk of delirium. Now, okay, back to this picture. I don't know why I have this picture. So next, how do we actually diagnose delirium? I would like to emphasize that to suspect someone having a delirium, it is very much a clinical diagnosis. All right. So even so, I think delirium has been around for many centuries, but it has actually not that long that people are actually becoming more aware of delirium. So even so, it can be very commonly unrecognized. I mean, there are studies that shows that even in the emergency department, you can miss like more than half of the cases who actually have delirium. And then occurrence of delirium by itself during admission to emergency department can range anything between 7 to 20% of patients. And even in ICU, more than half cases will be missed by ICU, by the nurses or the doctors. And remember that having delirium back in emergency department itself, if it's not recognized, is a predictor of increased 6 months mortality. So this is actually the most common tool that is used for assessing delirium. This is actually called the CAM score, and it has been used in more than 4,000 publications so far, translated in 12 different languages, and has been adapted to ICU and emergency. So it actually requires two cardinal features, which is acute onset with fluctuating force and inattention, plus either consciousness altered or atau and disorganized thinking. So this is actually, this CAM score is validated. It has good sensitivity at 94% and specificity of 90%. Aside from CAM score, there are other assessment tools. So I'll just divide it into those who are, what is it used for. So at the front door, we can use the CAM score, DCAM, CAM ED, and then for ICU, they tend to use the CAM ICU and ICD-SC. And then we have the format tool, and we have the more detailed research tools, and we also have tools that look at assessment of severity. The common ones is actually the delirium rating scale and the delirium index and the delirium severity scale. These are actually very long scale. So with all those tools, how do you decide which tool to use? So in general, when you need to be performing cognitive assessment to patients who presented to hospital, who are at risk, it should be part of our routine clinical practice to screen these patients for delirium. But whatever it is, whatever tool you use, it needs to be a tool which is accurate, a validated screening tool, easy to use depending on where you are and depending on the clinical setting. If you're in ED, there's no way you can do delirium severity scale, or 20 questions questionnaire and so forth. So you need to use the appropriate tool at the appropriate settings. So there are other settings and tools that I mentioned. There's the AMT4, AMT10, BCAM, and 480. In general, they actually have very good sensitivity pickup rate and actually good specificity as well. In ICU, they use the CAM score too, and then they actually modified it, and then it's a CAM ICU, and then we have the intensive care delirium screening check. So that's the CAM ICU score, and that's your ICD-SC score that you can look it up yourself later. So management. Initial management should really be to maintain the patient safety. You need to focus on the protection of the airway, prevention of aspiration, maintaining the patient's hydration and nutrition, prevent skin breakdown, and provision of mobility while also preventing falls. Of course, you need to identify the cause or causes. Remember, delirium is a medical emergency. You need to find the cause of the delirium, and you need to manage whatever symptoms that actually comes. And in the older person, delirium is a harbinger of medical emergency. all patients presenting with delirium should be screened for acute physiological disturbance. It's not enough to say that the patient has delirium. You need to find the cause of the delirium, what is actually causing the disturbance. It could be something as hypoxemia, hypoglycemia, or even a CO2 retention. And then remember, in an older person, they tend to have atypical presentation. For example, they might they might have a myocardial infarction and present with delirium. So they won't have the typical classic presentation of chest pain or shortness of breath. So a family member, when they complain that the patient is having, non-specific symptoms that suggest of delirium, it's very important that it should not be taken lightly, and you should actually screen and investigate the patient. And thirdly, a diagnostic assessment should be targeted on the basis of what you suspect, patient's history, and physical examination. Untargeted testing will actually have low yields and actually will be wasteful as well. So management, as usual, we can divide it into two: non-pharmacological or pharmacological. So non-pharmacological can be single component or multiple component. So okay, all right. So I'm just going to go to the types of non-pharmacological intervention. So these are the things that you can carry out for non-pharmacological intervention. These actually sounds very simple, and usually, in the hospital, you will try to do some, or if not most of it. First one is actually orientating. Second is education, offering hearing and visual aids, looking after the patient's sleep pattern and hygiene, to mobilize the patient earlier if possible, to control any pain, and ensure that the patient is having optimal hydration and nutrition. And don't forget to look at the patient's bladder and bowel function. More often than not, they actually present with chronic constipation as well. And infection control and oxygen supply. And very important to also look at the patient's medication. You need to do medication review, what needs to be stopped, what needs to be continued, what needs to be tapered down. And to detect and screen for delirium, ongoing delirium, or actually resolution of delirium, and also cognitive stimulation as appropriate. This is actually, just want to show you a quick paper looking at the systemic review and meta-analysis of RCT, looking at effect of non-pharmacological intervention for preventing delirium in a general ward inpatient. So these are for preventing delirium. So it's actually 17 studies. They look at 14 multi-component intervention. So what they found is that I think there was nine intervention that they found which is useful, which is actually early ambulation, staff education, having a good sleep routine, early mobility, and reducing sensory impairment and reorientating the patients. So those are the things that actually has good evidence. Okay, but unfortunately, most of the studies inside this RCT actually did not report the frequency and duration of the non-pharmacological intervention. How many times must you do staff education? How many times must you do orientation? It's not described in details, but nevertheless, most of them, if not all, actually do some form of multi-component intervention. All right. And this is actually another systemic review, which was actually done earlier. It actually shows the same thing, which is basically non-pharmacological intervention can actually reduce incidence of delirium. But they did say that for patients who have developed delirium, available evidence is not enough to support non-pharmacological multi-component intervention at this point. But remember, the risk factor to develop when you're deciding what non-pharmacological intervention to do, remember that the risk factors for patients are not the same. Their diagnosis is not the same, their presentation is not the same, they're very heterogeneous, and their frailty level is also different. So the risk factors for the patients are not the same. You need to tailor your intervention based on the risks that is likely to be beneficial to the patient, and it should be targeted. So to reduce the burdens on yourself as well and your staff as well. So in general, we know that delirium tends to be multifactorial. So in general, common sense tells you that maybe multi-component intervention would be actually will be useful. So these are the general recommendations that you can find online. One is actually the Hospitalized Elderly Life Program, which is a health program. It actually proposed that you correct 6 risk factors, which is cognitive impairment, sleep deprivation, immobility, vision impairment, hearing impairment, and dehydration. All right. So following from this, following from health, the National Institute of Health and Care Excellence NICE guideline also came up with a guideline to assess risk factor for delirium at the time for patient being hospitalized. So they actually recommended multi-component intervention consisting of 10 contents that includes disorientation. So following from this, the Scottish Intercollegiate Guidelines Network atau SIGN recommends reducing or modifying risk factors for delirium. That also includes preventing dehydration, hypoxemia, maintaining sleep, reducing psychological stress through communication and environmental management. And they recommend pharmacological multi-component intervention to prevent delirium. Now, briefly about pharmacological management. To be honest, when I look it up, there is not much randomized controlled trial with very strong evidence on pharmacological prevention of delirium. The most looked after research after medication would be haloperidol, which is actually based on, I would say, fairly small RCT, but a reduced trial and another RCT looking at prophylactic haloperidol in a subsyndromal delirium before it becomes full delirium doesn't show clear benefit. So not much benefit to prevent delirium. So there's another one, which is actually dexmedetomidine, which is a highly selective alpha-2 agonist receptor, which is actually can be used as a sedation. Apparently, there are studies that actually shows that it can reduce your delirium with an odds ratio of 3.5. They actually cause less agitation, but they are also associated with higher risk of bradycardia and hypotension, but it doesn't have any overall effect on mortality. Another medication that's being used is actually being looked at is actually ramelteon, which is a melatonin receptor and agonist. This is quite new. There are some meta-analysis and tri-sequential analysis that look at it, and actually sounds like it can actually be associated with lower odds of delirium compared to placebo, especially in the older groups. So, of course, when you want to prevent delirium, you should really avoid predisposing drugs. Just remember that certain medications can actually increase your risk for delirium. For every risk of delirium will be increased by 4% with every 5 milligram equivalent of midazolam. Okay, so be careful of your benzodiazepine. Use it when you need it and taper it down when you actually can taper it down quickly. So opiates is contradictory. If you have untreated severe pain, that itself can cause the risk factor for delirium. So adequate pain management is actually very important as well. So you may want to consider non-opiate analgesia, but this can also lead to other side effects such as hallucination and delirium. For example, if you use ketamine. All right. So there's very sparse conflicting evidence on the effect of drugs with anticholinergic effects and steroids. So it's not possible to make strong recommendation to avoid them. All right. So the treatment for when patient actually develops delirium, it has been commonly actually said to be haloperidol. It's the most commonly prescribed for the treatment of delirium. However, there is no clear evidence that haloperidol reduces the duration of the delirium. And some guidelines actually say that delirium should be restricted with those who are having severe agitation and psychosis. And there's limited evidence that atypical antipsychotic have fewer adverse effects than haloperidol. But the only benefit, I guess, your antipsychotics is atypical antipsychotics. The only strong benefit I could see in haloperidol is that you can titrate the dose and actually, titrate the dose to treat the patient. All right. So haloperidol or second generation antipsychotic studies have shown that it does not improve your length of stay in the hospital and not much change in your length of hospital in your duration of delirium per itself. Right. But, easier said than done. Yep, no improvement in length of stay, not much evidence on cognitive function and severity of burden. This is actually a review article. But having said that, as a doctor working in a hospital, there's a lot of challenges in managing these patients. All right, so we often, as a geriatrician, we often get referrals about patients with delirium. They're not sure how to manage the patients, and these are the things which is actually very challenging for them. One is actually psychosis. To be honest, there's not a lot of studies that specifically focus on the treatment of psychosis in the ward or in ICU settings with delirium. You're actually having like psychotic illness such as schizophrenia, treatment of antipsychotic is very much warranted. So, but if you need to give medication, the preferred agent for psychosis in delirium would be haloperidol again, because of its rapid effects and the possibility of, IV administration is possible. The next thing that people would always actually found challenging is the agitation. So the first thing that you need to do is to try to figure out, why the patient is agitated. It could be something very simple. The patient could be restrained and they're having like itchiness ataupun heat, or actually feeling very uncomfortable. You need to examine and look at the patient, whether they're having constipation or could it be a bladder retention? Is there a thrombophlebitis that actually causing them discomfort and agitation? So further reassurance and implementation of non-pharmacological measures should also be done to actually ease their agitation, all right, before you actually consider pharmacological management. And again, anxiety can be, you can also try non-pharmacological management, such as reassurance. And in some people, they actually try music therapy. In those cases where anxiety is extreme, maybe you can consider low-dose benzodiazepine. But remember, those medications with anxiolytic properties can also potentially prolong delirium. And of course, sleep. Benzo is commonly prescribed to promote sleep. However, benzo can, as mentioned earlier, induce delirium, although they may promote light sleep. But in the long run, they suppress your deep sleep and your REM sleep. So therefore, recovery. So one people say that you can actually consider to switch to quetiapine because it has some sedative effect to help you sleep, but it does not interfere much with your natural sleep. So delirium is distressing for the patients and the family. You need to consider a patient's risk by appropriate preventive intervention. Whenever possible, please screen and detect delirium. And it's very important to communicate with the patient, communicate with the patient's family, because it's very distressing, and you should follow up and reassess the patient. I would like to end my talk by a quote by Sir William Osler. The value of the experience is not in seeing much, but in seeing wisely. Look at your patients and interpret and do your assessment well. All right, with that, I thank you.
Thank you, Dr. Rosma.
Okay, let me unshare. I'm not sure how to do this.
Don't worry. Such a informative talk you gave just now. And I think delirium is so common that one of the most challenging is actually to diagnose it and to know which one of the patient is at the risk of developing delirium. Because delirium itself would actually lead to prolonged stay and all the complications. At the end of the day, morbidity and mortality are higher in this kind of patient. We are kind of open the floor for questions. But before anyone else asks question, maybe I could start. In your own experience in Hospital Kuala Lumpur, how much referral do you get for delirium actually? I'm sure it's going to be overburdening for your team.
Okay, so the good thing is that we commonly have CMEs. In fact, yesterday, my ward actually presented CME to the medical department on, to be serious about delirium. I'm not sure what the attendance rate was like, but we try to educate them as often as we can. In fact, last year, Geriatric CME, we also talk about delirium because we often get referrals about delirium. A lot of patients actually, if a person is not used to be seeing patients with delirium, they get very nervous to see patients agitated, and usually the easiest thing to do would be to restrain the patient.
Yeah.
So of course, when you restrain the patient's like agitated. So then they get stuck, and then they will refer to us for aggressive patients. Well, you know, there are many ways that they refer delirium to us. One is actually confusion, or one is actually patient probably have newly diagnosed dementia. Yeah, but delirium, you know, as we know, before you diagnose dementia, you really need to consider delirium. And having been in a hospital itself is a very big risk factor to develop delirium at any point. So always I tell the doctors, think of delirium before you diagnose them to have cognitive impairment of some sort. And we have to remind them again and again, delirium is a medical emergency. You don't stop at the psychosis. You don't stop at the anxiety and irrational behavior. You need to find out why they are actually delirious. Because some of them will just say it's just delirium, but delirium itself is not a diagnosis. There's actually a cause. There's an insult, as we mentioned before.
Yeah, I think there's certain easy things that we can do, like constipation, lightning, you know, some things that doesn't really need us to take over. Because majority of the time, I think when they refer to you, please take over care. Because very agitated in the ward, right?
Difficult to manage.
Yeah, yes. Okay. We have quite an audience today. I think about 120, 150 audience with us. How much time? Should I go on with the next question?
Yes,
Okay. I would say majority of the time the most difficult patient to manage delirium with if they are from the non-medical referral, so from surgical unit. And how will you I mean, they probably a bit I mean, they are not exposed, as you see. You can see a lot, but you have to see wisely. What is the simplest way? What is the tools? Because you have presented to us quite numbers of tools, and which one do you think that they might be able to use when they manage patient with delirium or detect a delirium in their ward?
I think, you know, sometimes it's easier to talk to the younger generation because some people, they just refer medical for acute confusional state. And I think it's easier for us to actually educate them, you know, earlier to talk about delirium, like the house officers and things like that. All right. So, and then sometimes when they refer to us, they're not so sure why the patient is having this abnormal behavior. So usually when they refer to us, we will see the patient, and these are actually post-operative patient. It could be anything: post-hip fracture, post-operation, post-intubation, post-whatever. So they will have, and then when they come out of ICU and they go to a medical ward, and then if you're not used to it, you of course get very panicked. So they will just refer to us. So we need to educate them, and actually the communication should be open. Okay, should be open between the operating team or with us. And usually what we tend to do, we give a lengthy advice on how to manage the patient. And the challenge is actually to see how they carry out the proposed plan. For example, we said, you know, try to avoid restraint, but sometimes, you know, understandably, easier said than done when your nurses is looking after 8 patients. And it's very difficult. Your patient is trying to jump out of the bed and there's actually no carer inside. Of course, sometimes, what I mentioned earlier, sometimes you need to give a bit more medicine, but you know, you give medicine at the lowest dose at the shortest time period. So usually I find that the other subspecialties are actually quite open when we discuss with them, and because we tend to follow them up, we tend to, you know how geriatricians are, we always find out what happened after that.
Sibuk.
And you follow them out. Sibuk. Usually, sometimes, occasionally, we do take over for some difficult cases, because some of the patients have very, very big geriatric giant to begin with. Like they might be having a lot of medical giants and then came in with appendectomy, you know, and then delirium. Maybe I didn't mention it before. Delirium can take a long time to recover. Like months.
True. Yeah. And it's going to be very difficult for them to discharge the patient if they continue to be in confusion state. We have one question from the participant. Okay, in a patient with underlying psychiatric disorder who presented with acute onset of abnormal behavior, how do you differentiate delirium from a relapse of psychiatric disorder in this setting?
So this is actually, I would say, like a common scenario when patient comes to emergency department. What usually happens is that we really need to rule out a medical cause, a medical or surgical emergency first, right? So usually that's what happens. Patient might have underlying schizophrenia, and then they will be found somewhere behaving erratically, and you
Mm.
cannot assume that this is actually a
Delirium.
relapse of the schizophrenia. You still need to do your workup to make sure, especially in the older patients, sometimes they don't present so typically. You cannot assume that it's the same thing and actually give them antipsychotics. You still need to do the relevant things, and treat what you can treat, investigate the cause before you can, once you rule it out, is only when you actually can, get the psychiatrist involved and decide that it is as it is. That's my short answer, but the answer is very long sebenarnya.
Yeah, you have to look for all the medical, surgical pain, ke, infection, ke, constipated, ke,
And
whatever.
I think it's the same for any hospital, even in they would refer, and usually we will see the patient first.
Yeah, true. Okay, I think that's it from us today. It's been quite interesting and wonderful. I think talking about delirium itself is something that is very, very important. Dr. Priscilla, so.
Thank you, Dr. Rosmahani and Prof. Dr. Izzati for this interesting topic. Meet all next week with another interesting geriatric topic again. With that, thank you.
Hi, Dr. Ahlam. I think for student, we will send them the e-certificate lah. Later, we will send. Because this QR code only for those MMA, means medical officer and specialists. Tak, ni untuk esok. Tak boleh untuk esok. Oh.